the Singapore chapter of ACC, and my co-chair, Professor Po Kian Kiong. I'd like to warmly welcome all of you to our webinar on lipid lowering to prevent cardiovascular events, State of the Art 2021. Today, we're very privileged. We have a very fantastic panel of speakers, Professor Tan Hui Chim, Dr. Paul Ong, and Dr. Natalie Koh will give us a talk on various topics on lipid management. And also we have a very privilege to have Professor Eugene Yang from University of Washington. He is the Preventive Cardiology Chair of the ACC. Very, very honored to have him today. And also we have Dr. Loh Lip Pin, Dr. Patrick Lim, and Dr. Ong Hian Yee would be our star-studded panelists for today. So let's go to the next slide. This is some of the disclaimers for this webinar. Next slide, please. And some housekeeping issues. So for Singapore registered physicians, nurses, and pharmacists, the CME and CPE points will be submitted for those who attend the entire duration of this webinar. And you can request also for your certificate of attendance after you've completed the survey at the end. There'll be a QR code sent to you, or you can see it at the end of the presentation. However, this session really is for all of you who are attending this webinar. So feel free to have robust discussions with the faculty using the Q&A button that you can see below. You can ask any questions you want, even controversial ones. You can raise it, and hopefully our panelists can have a very exciting time answering your questions. So without further ado, I'll pass on the mic to Prof. KK Po. He will tell you a little bit more about ACC and also introduce some of the speakers for today. So KK, please.
Thank you very much, Edgar. I'm just going to put up my slides. So this is from the Singapore Cardiac Society website. Feel free to join us as ordinary members, associate members for Allied Health. It's a very active society, and this educational program is under the umbrella of the SES. The president of SES is Dr. Ong Hian Yee. He's leading the discussion later on. So the American College of Cardiology Singapore chapter is parked under the Singapore Cardiac Society, and ACC is here to support you from training, medical school training up to retirement. And there are many membership types that you can join. Student memberships are free, international associate memberships, and also the FACC, Fellow of the American College of Cardiology. This membership unlocks access to resources and benefits that can help you improve patient care worldwide. We are able to connect and collaborate with many people around the world. There are 8 digital JACC journals available for all members. And up and coming is the JACC Asia, which is focused on this area. We also have exclusive webinars such as this and guidelines as well to help you. New this year, we have the FACC pathway calculator. So you can find out whether you are eligible to apply for the Fellowship of American College of Cardiology, even without submitting the application form. There's an app down for you to actually use to find out your eligibility. And for primary health care, as well as trainees, the ACC has developed this app called the NCD app. So it does not just encompass cardiovascular disease, but also cancer, respiratory disease, diabetes, and mental health. And very topical, the COVID-19, there's a COVID-19 chapter as well. So feel free to download that. It's also free for everyone, and there's a certificate if you complete the course. You can find out more from ncdacademy.acc.org. So lastly, I just want to talk about this, which we are organizing the ACC Asia together with the Singapore Cardiac Society. That's in July this year. It was postponed from last year because of COVID-19 pandemic. And this year, it will be virtual. So feel free to join us. It's going to be highly educational, and I'm sure you'll enjoy it. So before I introduce everyone, I'd just like to mention my mentor, the late Professor Chia Boon Lock. He came up with this yin and yang analogy to LDL and HDL in the formation of atherosclerosis. He also chaired the guidelines in Singapore on lipids from the first two guidelines, and this actually guide our practice on lipid management in cardiovascular disease and also lipid management in Singapore for more than a decade. So he has this slide which says that doctors who treat disease are mediocre, but if you can prevent disease, like all of you down here listening to this webinar, then you are considered superior doctor. This is by Huangdi Neijing, so it's 2600 BC. I'm very delighted to introduce Professor Eugene Yang. He's our guest of honor. He's clinical professor of medicine, and his chairship is aimed towards patient health. He's from the University of Washington School of Medicine, and I have a very nice chat with him immediately after the leadership forum for ACC, where we network. And he's going to join us. He's going to say a few words before he will join us at the end as a panelist for the discussion. So without further ado, Professor Yang.
Dr. Poe, thank you for the introduction, and Dr. Tay for inviting me to participate in the Singapore meeting today. It really is an honor as the incoming chair for the Cardiovascular Prevention Council for the ACC, and as a member of the ACC as a past governor for the Washington State chapter. You know, as I look forward to becoming the chair of the Prevention Council, I really want to change how I think the Prevention Council really incorporates a global perspective. I think with the initiation of the JACC Asia Journal, it's really an opportunity for the ACC to take a much more global approach to cardiovascular care. And as a preventative cardiologist who's very interested in understanding the differences in cardiovascular risk and outcomes in Asians versus other racial and ethnic groups, this is really an opportunity for us to work on research collaborations between cardiologists in the United States, as well as cardiologists in Asia and around the world, because I really believe that we, as the largest ethnic population in the world, we have really been underserved in trying to understand cardiovascular risk and differentiating cardiovascular risk among the large Asian subgroups and among even smaller Asian subgroups around the world. So part of my goal and mission as the incoming chair at the Prevention Council is to invite members from Singapore and other Asian countries to be involved in the ACC working groups in prevention, whether it's hypertension, lipid disorders, hyperlipidemia, as we're going to talk about today. And so I welcome all of you, or those of you who are interested in participating in some of the working groups as part of the ACC. So thank you, Dr. Koh and Dr. Tay, for inviting me today.
Thank you very much, Professor Yang. So let's start the ball rolling by inviting Professor Tan Hui Chim to give the first talk. Prof. Tan is a renowned cardiologist. He doesn't need any introduction. He's the current director of the National University Heart Center in Singapore. He's also a full professor of medicine with the Yong Loo Ling School of Medicine, NUS. He's a past president of the Singapore Cardiac Society and the chairman of the Singapore Heart Foundation. His CV spans a few pages, and it will take me more than half an hour to fully introduce him. But I've known him since housemanship, and he will give a fantastic talk. He's a renowned interventionist with a strong interest in atherosclerosis and therefore lipids as well. So without further ado, can I invite Prof. Tan? Thank you.
Thank you very much, KK, for the very kind introduction. So it's really a delight to be joining in this ACC webinar. So the topic that was assigned to me is risk stratification through coronary imaging and the role of lipid lowering on outcomes. I think first of all, we need to know that cardiovascular disease is a burden is really heavy in the Asia Pacific region. It's the leading cause of mortality in this part of the world, and more than 9.5 million people died from coronary cardiovascular disease in Asia in 2015. And when you look at Singapore, we have 17 people dying from cardiovascular disease daily. And cardiovascular disease accounts for 29.3% of all deaths in 2019. That means 1 in 3 people is going to die of cardiovascular disease in this country. And when we look at the burden of myocardial infarctions in Singapore, we have about 10,000 patients with myocardial infarctions every year that will include both STEMI as well as NSTEMI. The age standardized incidence rate appears to have increased slightly from 208 per 100,000 in 2007 to 216 per 100,000 in 2015, but this rise is not quite significant. So much of the rise in terms of the incidence is really related to the aging populations in Singapore. And we know that when patients develop myocardial infarction, the story is not over, because even with the best care of treatment, patients continue to develop recurrent cardiovascular events after that index event. So 6 months after discharge for myocardial infarction, you find that death continues to occur in about 8% of patients, and myocardial infarctions can recur again in 10% of patients. And when I was a fellow, I was always taught about this concept of a modifiable as well as non-modifiable risk factor. And LDL at that time was thought to be an LDL hypothesis. We don't really know whether LDL is really related to cardiovascular disease or not, but in current times and knowledge, we now know that LDL is definitely a leading cause of cardiovascular disease, and is the causal effective relationship is very well established and definitive. So what we need to know here is to understand the whole process of atherosclerosis. I think this is a picture that many have seen before, but I just want to highlight to you some of the important events here. When you are exposed to a high level of LDL cholesterol, in the first 3 decades of life, you may have a lipid accumulations within the intimal layer. But from the 4th decade onward, you could have plaque formations with the addition of smooth muscles and collagens into the atheroma formations. During the early phase of atheroma formations, it is actually non-progressive. So early phase will include intimal xanthoma, intimal hyperplasia, and this is usually termed not to be progressive. But once a atheroma enter into what we call a pathologic intimal hyperplasia, then this is a situation where the atheroma becomes progressive, and you can have a patient with gradual build-out of the atheromatous plaque. Now we know that there are 3 features of atheromatous plaques that really can cause cardiovascular events. When you have an atheroma volume that is high, when you have a lipid-rich core that is great, and when you have a lumen that is severely narrow, these are all what we call the trifecta for the prediction of cardiovascular event in the patients. Certainly when a plaque becomes very huge and unstable, it is prone to rupture and causing a thrombus formation leading to cardiovascular event. So it's very important that we identify this atherosclerotic process early and intervene to reduce the risk of cardiovascular event. Oops, went to the last. So this is an interesting slide, because when you compare the olden days of hunter-gathering human beings and compare it to the wild primates as well as wild mammals, actually our total cholesterol is pretty much the same. But when you have a modern human living a modern lifestyle, you find that the total cholesterol actually goes up a lot. And so when we are born as a newborn, the total cholesterol level is actually quite low. It's between 30 to 70 milligram per deciliter. And typically, as you grow older, it rises above 100 milligram per deciliter by age 20. But when you look at Singapore's average cholesterol level, LDL for Singaporean adult, this is 132 milligram per deciliter. So clearly, we have a fairly high level of LDL in Singapore. And just looking at the National Population Health Survey 2020 last year, again, we can see that there is an increased prevalence of hyperlipidemia in our local population of age between 18 to 74. So from 26% in 2010, now we are looking at nearly 30% or 39% last year. And there's this new concept here of a threshold for development of atherosclerotic cardiovascular disease when you are exposed to high LDL. So there's a threshold for development of disease, and this threshold can go up and down according to certain factors. It can be lower if you are male sex with smoking, hypertension, diabetes, and dyslipidemia profile. It can go up if you are female sex. But certainly what we do know is that when you're exposed to high level of LDL at a very young age, such as in patients with homozygous familial hypercholesterolemia, by 15 years of age, you would have reached the threshold for development of coronary heart disease. On the other hand, if you are a normal individual, normal lipid profile, your likelihood of developing a threshold for cardiovascular disease is above the age of 60. So I want to cover the topic in these two sections. One is to talk about the use of imaging as a form of a risk stratifier tool. And the second thing is to talk about the impact of lipid lowering on outcomes. So if you look at the guidelines of the various international associations, you can clearly quite see that there are actually two schools of thoughts here. On the left-hand side, this is the American College of Cardiology, where the guidelines really divide the patients into 4 risk groups, and there's actually no target of LDL to achieve. It's just merely identify patients whom you will start either high-intensity statin or low or moderate intensity statin, and looking at LDL percentage reduction, whether it's more than 50% or less than 50%. On the other hand, if you look at some of the rest of the guidelines, including Singapore guidelines, there are specific target LDL set for the various risk category of patients. But all the guidelines seems to suggest that statins should be universally used as a first-line therapy, with ezetimibe as a second-line therapy. And all the guidelines seems to also agree that 4 groups of patients will benefit from a lipid lowering. People with, number 1, established atherosclerotic disease, 2, diabetes, 3, primary LDL of more than 190 milligram per deciliter or 4.9, and primary prevention but high global risk. So Singapore guidelines, unfortunately, seems to be the oldest. It was published in 2016 as opposed to AHA, ACC in 2018 and ESC in 2019. But nevertheless, when we look at the Singapore guidelines, we actually identify 2 groups of patients whom we will intervene very aggressively: a very high-risk group of patients and a high-risk group of patients. The very high-risk will include people with established atherosclerotic disease, diabetes with some kind of target organ damage, but specifically here is a chronic kidney disease, and patients with familial hypercholesterolemia. So this fall under very high risk, and our target treatment is less than 2.1. And then we have a second group, which is high risk, where we include moderate to severe chronic kidney disease and diabetes mellitus without any established cardiovascular disease, the rest of which we will go on a risk sort of stratification. But clearly, when you look at the Singapore Ministry of Health guidelines, there was no mention whatsoever of using coronary calcium as a risk stratifier in many of the newer guidelines now. So if you look at the American College of Cardiology recommendations, again, there are 4 groups of patients that will benefit from statins: established atherosclerotic disease, more than 190 LDL, individual with diabetes mellitus. And I want to highlight to you now that this group of patients for primary prevention without any diabetes, without established disease, age 40 to 75, LDL of 70 to 189, if you use a ASCVD risk calculation of 10 years, now the risk bar has now been set at 7.5% 10-year risk instead of the past 10 years or more, 10% or more. So what is the ASCVD risk estimator? The risk estimator is pretty much same as our Singapore owned risk score, but except that diabetes mellitus is included here, and we actually break down the race by our own group of Chinese versus Malayan versus Indian. But anyhow, this is the American ASCVD risk. So if you key in the patient's data, if you want to calculate his 10-year risk, this is a 10-year risk of 9.3%. If you just key in some of the numbers, and then they will come up with recommendations and tell you whether to start the patients on moderate or high intensity statin. So this is how the Americans will work, and it will define high intensity and moderate intensity as atorvastatin 40 to 80 milligrams for those who are at highest risk, and moderate intensity will be those of atorvastatin 10 to 20 milligrams. The corresponding rosuvastatin would be 20 to 40, which is kind of high for a local population, versus rosuvastatin of 5 to 10 for a moderate intensity. I want to highlight to you the ASCVD target group of this group of patients who are basically for primary prevention, where the risk is deemed to be sort of moderate. And this is where the use of a calcium score becoming important here as a risk modifier. So when you look at the calcium score here in greater details, if you have a patient whose risk is between 7.5% to 10% and so forth, one can look at the patient's coronary calcium score and decide if statin therapy should be commenced. If your calcium score is 0, then perhaps for over the next 5 to 10 years, you may withhold your statin therapy because these are considered low risk. But the moment your calcium score is 1 to 99, and if you're of the age 55 and above, then it is reasonable to initiate statin therapy. If your calcium score is 100 or higher, perhaps it is reasonable to start statin therapy right away. And this is supported by the data from the MESA trial. So what is this calciums in the coronary artery? Well, the presence of calciums basically indicates the presence of atheromas in the coronary artery. In fact, the presence of calcium is an indicator of the disease duration as well as the activity. So the higher the calcium score indicates a greater atheromatous plaque, and it actually predict event. In the MESA trial, for example, looking at 10-year incidence, if your calcium score is 0, then your 10-year event rate is less than 5%. But once your calcium score is more than 100, then your 10-year event rate 7.5%. We have our own local data from Heart Center. 10-year event rate for our local population with calcium score of 0 was actually only 1% in our patient population, indicative of a very, very low risk of patients that we are dealing with. So the MESA also tells us that actually there's no single risk factor that will predict which individuals would maintain a calcium score of 0 over the next 10 years. So it is not a particular risk factor like lipids or smoking. In fact, it is the entire maintenance healthy lifestyle of the individual that will ensure that the artery remains healthy as opposed to an individual risk factor. This MESA study was actually corroborated by the cardio trial, which again tells us that if you follow up patients with any sort of a calcium score over a long period of time, in this case, this is about 3,000 patients follow up over 12 and a half years, patients with calcium score of more than 100 had an incidence of 22.4 deaths per 100 patients on follow-up. So here, even in patients with very low calcium score, there is still a significant risk in the next decade as you follow this individuals up. So what about the role of calcium score versus Framingham risk score and versus the treadmill test that we commonly do? If you add on a calcium score to an individual who is already stratified by Framingham risk score, you actually improve the risk prediction in this particular study. So adding on calcium score, if it's less than 10, incidence rate is now 0.6% per year and 3.7% per year if it's more than 400 for calcium score. So if you look at the European recommendations, calcium score now with CT scan may be considered as a risk modifier in the CV risk assessment of asymptomatic individuals at low and moderate risk, and this is a class 2B recommendations. On top of that, the ESC looks at specific findings on the CT scan. So if you have a calcium score of more than 100, if you have multivessel coronary artery disease defined as 2 major epicardial arteries having more than 50% stenosis on the CT scan, you are considered a very high-risk group of patients for which early intervention is required. Certainly, the presence of carotid femoral plaques and extreme LP little a elevations are also considered to be features of very high-risk individual. So if you compare the ACC and the AHA together, both recommend calcium score, but ACC did not incorporate chlorotic plaques in the risk stratification, whereas the European do. Both also recommend ABI as a risk enhancer. So who are the patients that will really benefit from knowing their calcium score? And this is a good group of people whom you will consider doing calcium score. And if the calcium score turn out to be 0, it will actually benefit them a lot more. So for example, patients who are reluctant to initiate statin therapy and who wish to understand their risk and potential for benefit more precisely, then you may consider doing a calcium score. If it's 0, then you don't have to start. Patients who are concerned about the need to reinstitute statin therapy after discontinuation for statin-associated symptoms, this will be another group. And older patients and people who are really not convinced about starting statin, use a calcium score as a risk stratifier. So what about the impact of lipid lowering on outcomes? This is the early data from statin trials that we all know about. That there's a linear relationship between lowering LDL cholesterol and the incidence of a coronary heart disease event. We at that time in the 10 years ago weren't sure whether if you go below 70 or go below 50, will there be a S J curve that will cause an increase in terms of cardiovascular event? That concern has now been addressed with the later trial. Now we can clearly see that in patients whom we lower the LDL to a rock bottom, even less than 40, you continue to see a secondary preventive effect. So there's no such thing as a low LDL cholesterol level anymore. In fact, it's going to be as low as you can. Even in patients whom we deem to be very low risk, primary prevention, where we say that the 5-year risk event is less than 10%, lowering the LDL in these individuals continue to produce benefit. Every 1 millimole reduction in LDL produce an absolute reduction in event of 11 per thousand over 5 years in this particular study. So if you look at this meta-analysis, looking at the genetic studies and pharmacologically lowered trial, one can now tell that if you have a long term of high cholesterol level for a long period of time, and if you reduce the LDL a lot by a higher magnitude, you actually derive greater benefit. So there is actually a dose-dependent reduction in the risk of major atherosclerotic cardiovascular events that is proportional to the absolute magnitude of the reduction in achieved LDL. So lower the better. But having reduced LDL in our patients, I just now mentioned that patients continue to develop events even with best of care. And that's this concept of a residual risk. So when we lower the risk of a patient through all this pharmacologic as well lifestyle intervention, actually at this point in time, we do not eliminate the risk of patient developing cardiovascular events. We just merely reduce the occurrence of this event. So there's this whole concept of residual risk in the patients that perhaps if we lower the LDL further, could that bring about benefit? And this will be covered in the next topic here. But what we do know is that besides statin therapy that worked in terms of reducing event, the newer cholesterol lowering therapy also worked. For example, ezetimibe in the IMPROVE-IT trial tells us clearly that the addition of ezetimibe to simvastatin brings about a further reduction in terms of ischemic event. In the era of PCSK9 inhibitors, FOURIER trial tells us that even in the low-risk group of patients, the further reduction of LDL continues to bring benefits to the patient in terms of a reduction of major adverse cardiac event. So this is something that we are now looking at very closely. When you look at all this contemporary data, it is really promising with regard to the further reductions of LDL using some of the most powerful cholesterol lowering therapies such as PCSK9 inhibitor. So finally, I just want to talk about this concept of atheroma reductions. Many patients will ask me, when you take a lipid lowering therapy, do we get the disappearance of the plaques on the angiogram? The answer here is that it is, to a certain degree, it is true. But the angiographic reductions of plaque is actually very minimal, something like less than 5%. But what is more important to the patients when you're on high-dose statin therapy is that you bring about a change in terms of the composition of the plaques in the patient's coronary artery. The reduction of plaque atheroma volume is being clearly demonstrated in many clinical trials. For example, in the reversal trial of using atorvastatin at 80 milligrams and following these patients up on using intravascular ultrasound, you can see that there is a clear reduction in the atheroma area in this group of patients who were given to high dose intensity statin therapy. Nowadays, when we use OCT, which is an infrared imaging, which is even clearer in terms of its resolutions, where we now can possibly even measure the fibrous cap of a patient atheroma. And if you compare atorvastatin to 20 milligram versus 5 milligram, you find that there is a significant reduction in the lipid core, such that the plaque fibrous cap thickness now increased so much compared to a baseline therapy, whereas there's not much of a change with 5 milligram atorvastatin. So clearly, statin therapy is working in terms of modifications of a patient's coronary plaque. So in conclusion, Mr. Chairman, I would just say that there is a significant cardiovascular disease burden globally. There is the causative relationship between LDL cholesterol and CV disease is well established, and there is a role for non-invasive imaging as a tool for screening and for further optimization control of dyslipidemia as a modifiable risk factor. Thank you very much for your attention.
Thank you very much, Professor Tan. There's so much data in there. I'll encourage participants to put in your questions, which will be addressed at the Q&A Friday. I look forward to the next talk. The next speaker is Dr. Paul Ong. He's from my alma mater, my senior from Cambridge University. He is established interventionist, consultant at Antoxing Hospital, and also at Mount Elizabeth Novena Hospital. So can we welcome Dr. Paul Ong, please?
Thank you very much, KK, for the kind introduction. It's obviously my task today is to talk about LDL lowering in the higher risk patients, and particularly how low should we go. And first of all, thank you very much to Singapore Cardiac Society and ACC Singapore chapter to invite me to give this talk. It's always a little bit more challenging to follow Hui Chim's lecture, because he kind of really quickly gave us a tour de force of how to manage LDL cholesterol from across the spectrum. I'm also acutely aware that I'm giving the talk around about 1:30, and a lot of you will either be really hungry or just had your lunch. So the attention span, I thought I would make the best out of it. So I put up this first slide here. So if you don't take a lot away from me today, maybe the important message is out. We really have very good tools and powerful drugs to control the LDL now. So looking at using the statin alone, a high intensity statin plus acetamide, and then we can also bring in PCSK9, and you can see the LDL cholesterol really doesn't stand much chance, and we can actually have tools to reduce it by up to 85%. So this is a slide that was shown by a previous speaker, looking at the primary prevention. So we always talk about LDL in terms of primary preventions on those patients who have not declared themselves having cardiovascular disease, compared with those who are secondary prevention, who already had an event, either being acute coronary syndromes or peripheral vascular disease or strokes. So in the primary prevention group, let's have a look at it. I mean, Hui Chim already mentioned about this slide, but I also want to highlight, the patient.
Sorry, interrupt. You probably need to share your slides.
Oh, sorry. Let me try again. Sorry if that's the case. Okay, let's try that again. I won't go into all those again, so I apologize for that. Okay, so we're here. Those patients who have a higher risk group are those with scores that put them in a particular group where your risk of cardiovascular events is high, and this is where we should bring in the cholesterol management quickly to reduce the LDL cholesterol by more than 50%. So again, there was the calculator that was shown by Hui Chim earlier, but what we are really looking at is your gender, your blood pressure profile, and your baseline cholesterol and diabetes. And with that, you can actually work out based on your age of the patient, roughly where is your atherosclerotic cardiovascular risk is. This kind of slide will repeat over and over again, and I make no apologies to show that once again here. Reason for that is for patients who are having a relatively, or population, should I say, who have a relatively low risk, starting around about here, you can probably be a little bit more tolerant of the LDL treatment level. But in those who are particularly high risk, you can see that the cardiovascular risk are very high. Your cholesterol level needs to be lower. Lower the better is probably the message here today. LDL of 1.4 is the newest target in the latest ESC update in 2019. So here we are looking at patients who have family history of atherosclerotic disease, CKD, GFR less than 30, diabetes with features of target organ failure and damage. And when your LDL cholesterol is lower to about 2, you can see that it doesn't matter at what stage you are. Lower LDL reduce the major cardiovascular event even further, be it those at relatively low score of 5 to 10%. If you drop the LDL further, your event rate dropped. But in particularly those who are very high risk, lowering it from 2 to 1.5 to 1.0 further reduced the cardiovascular risk event. The topic today is about high-risk patients. So here I want to share with you a case or a patient that I've been looking after for quite some time. This is a gentleman who is now 54 years old, but when he first came to me, he was walking on the travelator at the airport. He has a risk factor of a hypertension on therapy. His father had bypass in his 50s, and his baseline LDL was 4.2 when he first came to me. At the time, he already had coronary artery disease and underwent 2 stent implantation in another center, and his right coronary artery also had moderate lesions. So when I saw him, he already had symptoms when he was walking on the travelator I mentioned, and this is his coronary angiogram in 2015. He already had progression in his left main coronary artery. His coronary artery physiological study demonstrated flow-limiting lesions. And in light of these findings and the fact that he already had quite extensive angioplasty done, I actually asked him to go through a coronary artery bypass surgery, which he had subsequently with a Lima to LAD and an arterial graft to the circumflex artery. He did okay, no angina, but he had real difficulty tolerating the statin. A lot of complaints about aches and pains, nightmare, hair loss, you named it. And he's been really inconsistent in taking his drugs. So I had him on Crestor, ezetimibe, and fenofibrate, but the compliance was really challenging. So now I fast forward 2 years after struggling with his cholesterol management, he once again was walking in a travelator. But while he was having cold sweat and discomfort, he was spotted by his traveling companion, who happened to be a professor in cardiothoracic surgery. And very quickly, he got referred back to me. An angiogram this time showed further progression of his coronary artery disease. Luckily, his bypass graft remained patent, but you can see compared with 2015, his distal RCA developed further lesions. So that was treated. This will be his 3rd revascularization. So I'm going to pause a little bit and go and to look into some of the new tools that we as physicians can have in managing these patients' LDL. I'm going to talk a little bit about FOURIER trial that was mentioned earlier. But before that, I want to spend a little bit of time for those who are not familiar with PCSK9 inhibitors, what the role is. So we know LDL, low-density lipoprotein cholesterol, is the one that is, causing as a prime culprit in the atherosclerotic process. In the liver cells, we also have LDL receptors that grab this LDL, internalize them, and the lysosomes, and where the LDL cholesterol get disposed. The receptors will then move back up to the surface to continue to capture more LDL and hence lower our body defense mechanism and lowering LDL. However, there is this bad guy called PCSK9. It binds together with the LDL receptors and the LDL. Now the whole complex, the 3 bodies of them, enter the liver cells, and at this point, both the LDL and the LDL receptors are degraded. So now the LDL receptors are not recycled back, and therefore you kept the number of LDL receptors low, and therefore allow the LDL to build up in the bloodstream. Okay, so in some way, this PCSK9 kind of chaperones the LDL receptor to destruction, almost like the Grim Reaper. You have it, the LDL receptors doesn't survive much longer. PCSK9 inhibitors stop the degradation of the LDL receptors, because when PCSK9 inhibitors such as evolocumab are in place, these are antibodies that bind, specifically stop the PCSK9 from binding to the receptors, and therefore kept the LDL receptors working much longer and can be recycled back to the surface to continue to bring the LDL down. In the FOURIER studies, the objective is to test whether the addition of evolocumab reduces the incidence of major cardiovascular events. I think Hui-Chin had very quickly covered this trial. I will very quickly run through it. There's a large-scale study with 27,000 patients involved. These are patients who have established cardiovascular disease. So these are the high-risk group of patients. They're already on statin, some of them also on ezetimibe, and they are now randomized to either receiving the PCSK9 inhibitor or placebo. The endpoints, hard endpoints they looked at, cardiovascular death, MI stroke, unstable angina, or revascularization. And again, hard endpoint for secondary disease. No surprise that the LDL got really severely lowered when the patient is on PCSK9 inhibitors, 59% reduction. And these are patients already on statin and some of them on ezetimibe. When we look at the primary endpoint and the key secondary composite endpoint, both of them are significantly reduced. And in terms of outcome studies, when you break it down, you can see that the cardiovascular death, MI strokes, all independently more or less achieved significance. But our patients, remember, already had 3 episodes of revascularization. This is what we really want to see. The coronary revascularization risk should be lowered, both in terms of urgent and elective surgery. So this is a summary slide of the FOURIER study, looking at the primary prevention, primary endpoint and secondary endpoint. Both have a hazard ratio reducing the risk by 15% to 20% for the major cardiovascular risk. So I'm coming back to my patient. So I put him on Repatha, 140 milligrams fortnightly. After a month, his LDL dropped from 2.8 to 0.2. So surely, would this prevent him from disease progression, especially in terms of repeat revascularization? And if so, how? I'm going to bring up a slightly less talked about study called the Gladkov study. And this is looking at the effect of PCSK9 inhibitors on the progression of coronary artery disease in statin-treated patients, similar to what Hui-Chin mentioned about the use of atorvastatin here. A very quick summary of that is after roughly about 1.5 years of using evolocumab on these patients, you can see that statin monotherapy, using IVUS to assess it, the plaque disease really didn't change much. In fact, if anything, gone up a little bit. The use of statin plus PCSK9 inhibitors, you can see there is a reduction in plaque burden. Now, one can argue that the reduction is only 1%. Maybe not as striking as earlier study, but for 18 months period, there was no progression, but actually a regression of the plaque burden. I think that's the important take-home message too. So you can see that in the Gladkov study, not only did they achieve LDL lowering very dramatically, but they also have the first time demonstrate that using these more powerful tools, you can actually regress the plaque burden. What happened to my patient? This is his LDL chart. And I must say, when I look at this chart, preparing this talk, you can see how his compliance has been fluctuating over that period of time. So right about Christmas time, just passed, I got a phone call from my friend saying that Your patient is again not doing too well, been admitted himself to the emergency department, and we also noticed that troponin gone up a little bit too. And this is his coronary artery disease. He previously had a pretty okay mid-RCA, but he developed new lesions. So that was quickly again treated, but that would be his 4th revascularization. So what else can we do to him? Obviously, his cholesterol LDL really needs to be controlled. We can talk about the other issues like inflammatory hypothesis, but there is still a modifiable disease pattern that I haven't really quite achieved with him. That brings me back to today's main topic: how low can we go? Looking back at the Fourier study, they actually looked at those patients and divided them into different subgroups. After 1 month of treatment with evolocumab, those achieved really low LDL level of less than 0.05 millimole or 20 milligrams level, compared to those 2.5 to 1.3, etc. How do they compare? The baseline characteristics for these subgroups are all very similar. In fact, those on the higher end may just be receiving a little bit more acetamide. And you can see the LDL cholesterol over time developing the very different group, the purple ones being extremely low LDL-C cholesterol. And the message here is, in terms of cardiovascular death, MI, stroke, unstable angina, and coronary revascularization, is the continuous curve. Those who have achieved lower LDL all the way down here, the event rates continue to drop. There is also almost no cutoff as where they will stop benefiting from it. And in terms of the secondary endpoint of cardiovascular death, MI, and stroke, the same phenomenon you can see here. Despite lowering the cholesterol down to that kind of level, it doesn't seem to be any difference in terms of adverse events: new diabetes onset, cancer, cataract, cognitive disease, liver enzyme change. Safety signals remain very consistent, no difference. And in exploratory analysis, for those who achieved a low level down to 0.26 millimole or less than 10 milligrams per deciliters at 4 weeks, you can see that the benefits compared with those who are 2.6 continue to show a very dramatic improvement, with a hazard ratio down to almost 0.7 and no safety price to pay. So the conclusion from this sub-analysis looked at LDL-C can now be reduced to an unprecedented level with PCSK9. And there's a strong progressive relationship of achieving such low level of LDL with this accomplishing CV events lowering. And there was no extra safety signals. I left this slide. This is the beginning slide that I started the talk, which I didn't really show because I wasn't sharing my screen. But here you are. We can really lower the LDL-C and achieve a benefit for our patient. And for my patient, I hope that he will also stick with the medication that I prescribed him and stop him from getting this 5th revascularization. So the race is to 0, let the LDL-C drop. Thank you very much for your attention.
Thank you very much, Paul. That was an excellent lecture. Your case also illustrates sometimes difficulty that we have with trying to treat patients. We have all these tools, but some of these tools may also have some adverse effects. So to address some of these issues, we'll have our next speaker, Dr. Natalie Ko. She's a consultant cardiologist at the National Heart Center. She's subspecializing in echocardiography, and she gives very good lectures on lipids. So without further ado, I'd like her to give us a talk on statin intolerance and how to manage some of these patients. Natalie, please.
Thank you, Prof, for the kind introduction. And thank you for the kind invitation today to speak about how to manage patients with statin intolerance, as well as some of the side effects. I apologize. These are my disclosures. Okay, so I think Prof. Tan and Dr. Paul have all mentioned about the benefits of statin therapy. And it is imperative that before we convince our patients about the value proposition of statins, as physicians, we must be convinced of the benefits of statins ourselves. And I think on screen, we have data points that will guide our discussion in a risk-benefit discussion with our patients. So in the hallmark analysis of 14 RCTs of 90,000 participants, known as the Cholesterol Treatment Trialist Study, it was found that over an average of 5 years, statin therapy, which resulted in every millimole of LDL-C reduction, led to a 21% reduction in MACE, a 12% reduction in all-cause mortality, and a 19% reduction in coronary mortality. And at 1 year of treatment, compared with less intensive statin treatment, more intensive statin treatment led to an additional 15% reduction in MACE, especially for patients whose LDL-C at baseline was more than 4.2. And we know that patients who are on statin therapy for up to 6 years, the number needed to treat is 250 for death from any cause and 500 for CV death. What about Asians? Multiple RCTs in Asia confirmed the generalizability of CVD risk reduction benefits of statins as well. And in fact, Asian patients achieve their LDL-C goals with lower doses of statins compared to their Western counterparts. Are we achieving our statin targets? How are we doing on that front? Well, sadly, a large proportion of at-risk statin-treated patients fail to reach optimal LDL-C targets. And you can see on screen that it ranges from between 24 to about 60% in Western cohorts, even for those that are at high risk. And one of the major reasons for ineffective lipid lowering with statin therapy is actually treatment withdrawal because of concern or appreciation of side effects. In observational studies with sample sizes up to the hundreds of thousands, statin discontinuation rate ranges from about 8% all the way to 54%, mostly ascribable to statin intolerance or its side effects. And we know that stopping statin therapy is likely to be followed by increased risks of CVD and mortality with an odds ratio of up to 1.18. However, what is not often known is that statin rechallenge is actually eminently feasible based on real-world studies. Among patients discontinuing statins, 37% to 59.6% were actually receptive to reinitiating or switching statins. And aversion to statins actually declined with time among patients who had discontinued. At 5 years, 80% actually retook their statins. And third, the adherence rate was high after rechallenge. We're looking at between 73 to 92%, with few patients experiencing a relapse of intolerance that precluded their statin treatment therapy. Another point that I want to make is also that of questionable causality. There is a big disparity between adverse event rates in clinical practice versus randomized controlled trial data. In most observational studies, the reported AE rates were more than 10%, compared to randomized clinical trials, where adverse events occurred at much lower rates and were comparable between the statin and control groups. And most of the reported adverse events were mild and did not actually require discontinuation. And this is the discussion about the nocebo effect, where patients went on chat groups, forums, WhatsApp groups, Telegram groups, Signal groups, what have you. You know, after osmosis between their friends, etc., it might actually affect their perceptions of adverse effects. And this is very beautifully demonstrated in the ESCOT LLA study, where muscle adverse event rates were similar among patients on statins versus placebo in the blinded phase. But when it converted to a non-blinded, non-randomized, open-label treatment phase, they were actually higher among statin-treated patients versus those who weren't on statins. Moreover, most of the adverse events reported in clinical practice were not producible under the randomized, double-blinded conditions in RCTs. I do take this factoid with a little pinch of salt for two reasons. Firstly, because many RCTs, the run-in phase actually excluded patients with symptoms as compared to real life. And secondly, not all RCTs actually adjudicated for muscle adverse events with proper structured questionnaires at each and every trial visit. So I think the truth is actually somewhere in between. So what about Asians? Well, Asian patients differ from Western patients in the pharmacokinetics of statins, largely due to the genetic variants in the CYP450 gene. The lower metabolic activity of CYP450 in Asian cohorts actually leads to higher plasma levels of statins. And this actually is related to the misconception that Asians may be at an increased risk of side effects. And so statins are underused and the achievement of LDL-C goals remains suboptimal in Asia. If we look at the numbers, it's similar to what I presented earlier for the Western Hemisphere. Real-world data in Asian countries, statin discontinuation about 33% to 60%, suboptimal LDL-C goal attainment 20 to 60%. Adverse event rates range from 10% to 20% in Asian observational studies, but the predisposition to statin intolerance in Asians is not supported by RCTs. Muscle adverse events occurred at lower rates, mostly less than 10% in RCTs of Asian patients compared to Western cohorts, were rarely serious, and were not higher in statin versus placebo arms. What is the definition of statin intolerance? How do you define it for yourself? How do you face this with your patient? I'm sorry, I don't have a straight answer. There is really no uniform definition for statin intolerance in the literature, but I will give some pointers coming up soon. Presumably, statin intolerance occurs when a patient is unable to use a statin, either because they develop a side effect or because a blood test shows elevation or derangement of certain markers like liver function or muscle function, which are abnormal enough to cause concern. The intolerance can be partial, some statins at some doses, or complete, all statins at any dose. The most common presentation of statin intolerance is muscle symptoms, which will be the focus of our discussion coming up. What are some of the potential mechanisms for statin-associated muscle symptom development? So I'd like to draw your attention to what's happening on the screen now. We have divided the statins into lipophilic as well as hydrophilic statins. Well, in theory, the lipophilic statins are supposed to have slightly higher predisposition because of the ability of the statins to diffuse non-selectively into extrahepatic tissues like skeletal muscles. The lipophilic statins are supposed to academically put the patient at higher risk of statin-associated muscle symptoms. Contrast this with the hydrophilic statins like rosuvastatin, pravastatin, which have less muscle penetration and therefore theoretically a lower risk of statin-associated muscle symptoms. So when it comes to the various pathways and multiple mechanisms that give rise to statin intolerance and its associated symptoms from statins, it's beyond the scope of this discussion. Suffice to say, multiple cell signal pathways, protein signaling activity, affect membrane cholesterol content, its stability and fluidity, and gives rise to this phenomenon, a very heterogeneous phenomenon. I think a lot of us in the audience have questions with regards to CoQ10, whether it's among the community or between us and our patients. It is theorized that some muscle side effects may be related to the effect of statins on energy metabolism, or that the symptoms are attributable to reduced levels of coenzyme Q10 in muscles. However, there is insufficient evidence to show the usefulness of CoQ10 in the treatment of statin myalgia, or even in improving adherence to statin therapy. So yes, in theory, but not really proven clinically to work. So statin-associated muscle events, myalgias may occur in up to about 15% of treated patients, and the symptoms are mostly mild and rarely associated with myositis and or elevated creatine kinase. Per 100,000 patient year treatment with statin, it was estimated that muscle adverse events occur in fewer than 100 to 200 cases, with CK elevation in only 10 cases out of these 100,000 patient year treatment with statins, and rhabdomyolysis vanishingly rare in 2 to 3 cases out of this lot. So we have a lot of guidelines here, and the academic organizations have provided discrepant definitions for myalgia, myositis, myopathy, and rhabdomyolysis. And the confusion arises mainly from what you use to define each of these categories based on CK levels. I will show you another slide after this to unify all these multiple academic bodies' definitions. But what I want to draw your attention to is the red box on screen, which again corroborates the very low actual incidence reported in RCTs of any of these 4 events. So Lee et al. Actually published a very pretty diagram you see on screen, reconciling all these proposed definitions. And the definition of rhabdomyolysis in this categorization being that of a creatinine kinase of greater than 40 times the upper limit of normal. Myopathy defined as creatinine kinase between 10 to 40 times the upper limit of normal. Myositis, if you have up to 10 times the upper limit normal of CK, and myalgia if your creatinine kinase is not affected. So here we see that we have more guidelines trying to define statin intolerance. The Canadians, the ILDP, International Lipid Expert Panel, the Asian Guidelines, Japanese Atherosclerotic Society, National Lipid Association, Taiwan Society of Lipid Atherosclerosis, all posit their own definitions of statin intolerance. Summarizing all of this, in our practice, I think this slide is pretty useful. These are the 4 elements I would consider before deciding on labeling my patient statin intolerant. First, establishing what clinical manifestations the patient is complaining of, or where there are objective clinical measures that are abnormal, the biomarkers, ALT, CK. Second, what are the types and doses of statins that have been used in the course of treatment? Is the patient unable to tolerate 2 or more types of statins, especially if one of them has been used in the lowest daily dose? If so, more likely than not, statin intolerant. Third, the temporal and causal relationships. Well, adverse events commence after the initiation or up titration, remit upon discontinuation, and reappear after re-challenge. But life is hardly so perfect. But in general, that is the temporal causal relationship we would expect. Fourth, we would want to exclude other possible causes that, for example, the event is associated with other clinical conditions, which I will show again in another slide, what could potentially trigger these symptoms that could be potentially reversible. And sometimes certain drug-drug interactions, for example, the patients are on CYP3A4 inhibitors or are taking grapefruit juice. So these are things that would help shift the needle one way or the other when we want to seriously label as someone as a statin intolerant and deprive them of the benefits of statin therapy potentially. So this is a very useful questionnaire, a risk score, if I would say so, the statin-associated muscle symptom clinical index. It's very useful, it's easy to apply, it helps quantitate whether your patient is probable, possible, or unlikely to have a statin-associated muscle symptoms. And it resolves a lot of the issues that we face when we randomly ask patients by structuring the questions in a standard manner with vetted language, easily interpreted scores, and proven inter-rater reliability. So this was published, I think, in 2015, and then again in a few more review articles in 2020. Whether or not it has been validated in multiple cohorts is still ongoing, but I find it extremely useful and objective when asking the patients. So the symptoms of SAMS are often non-specific and largely localized to the proximal muscle groups, such as thighs, buttocks, calves, as you will see if you were to compute the score based on this questionnaire. So as promised, we will talk a little bit about the risk factors associated with SAMS, and they are female, gender, advanced age, obesity, frailty, vitamin deficiency. However, caveat, there's no evidence of benefit from vitamin D supplementation, even in patients with insufficient levels to prevent statin-associated myocardial symptoms. So sorry, even topping it up doesn't ameliorate the symptoms that they feel. And just drawing your attention down, hypothyroidism, of course, we know, and family history. If they have relatives who have a history of statin intolerance, more likely, maybe they do have it for real. So what do the guidelines recommend when it comes to statin intolerance therapy? There's so many guidelines, and this table summarizes well-accepted guidelines and consensus recommendations in relation to statin intolerance published outside of Asia between February 2015 and February 2020. They are quite similar to the Asian guidelines that you see on screen. And basically, I will be going through workflows as well as flowcharts for management that to be recommended. In summary, the guidelines are unified in that they would say, unless you have good proof of statin intolerance through iterative, structured questioning, reasoning, and repeated discussion, you should persist, because the benefit, the value proposition of statin is such that we really should not be depriving patients unnecessarily of such good things. So before I move on to a discussion about managing what are some of the, what is the most common side effect, which is muscle symptoms, let's get some of these adverse events that we hear and chatter out of the way. Well, there are three, and these three have been reported to be associated with statins. Many occur at a low rate, are mild, or actually have a spurious relationship with statin use. First, changes in liver function. Well, let's put it this way, the US FDA does not consider this adverse event to be alarming and no longer in fact requires LFTs to be routinely monitored. Okay, I think that's very telling. Secondly, what about hemorrhagic stroke? What about the Sparkle trial and the Chinese meta-analysis? Well, it's still debated, but what is undeniable? The low incidence rate, 5 to 10 cases out of 10,000 patients treated over 5 years. And it is also overly superseded by the benefit of ischemic stroke prevention through a huge body of literature. Third, newly diagnosed diabetes. Well, it is estimated to arise in about 50 to 100 cases among 10,000 patients treated over 5 years. But it is, in general, a low incidence side effects of statins, especially in patients who are already at risk of developing diabetes. This particular incidence rate is actually most predominant in patients who have impaired fasting glucose. And it can be argued they are at even higher risk than patients who have normal sugar levels. So it shouldn't be something defined as an intolerance that impedes treatment adherence. So when we talk about managing statin intolerance, the approaches can largely be grouped into statin-based approaches and non-statin approaches, with statin-based approaches being prioritized over non-statin approaches. There are 3 ways you can use statin-based approaches to help your patient navigate statin intolerance. The first is, okay, we can consider switching to another statin, from one statin to another, or switching from brand name to generic statins. Second, reducing the dose of statins. And third, intermittent dosing with statins. Now, this is a very interesting proposition. I'll show you some data that shows, hey, perhaps it's a reasonable proposition. Non-statin approaches, 2 ways. You combine the non-statin with maximum tolerated statins, or we use monotherapy. So how about statin-based approaches? I'll draw your attention to the third point, intermittent dosing with statins and reducing the dosing frequency. Well, actually 2 studies, a meta-analysis found no differences in LDL-C reduction between alternate day versus daily dosing regimens of atorvastatin and rosuvastatin. I think this is really interesting. Second, the efficacy of rosuvastatin taken once or twice a week in statin-intolerant patients was reported in 2 preliminary studies, supporting them as possible solutions. The references are on screen. For non-statin approaches, we have long known about the LDL-C lowering efficacy of ezetimibe, bile acid sequestrants, fibrates, and remarkably, the PCSK9 inhibitors, all supported by evidence. For secondary prevention of CVD, PCSK9 inhibitors were demonstrated to reduce MACE by 15 to 48% in clinical trials, with no safety signal with regard to muscle adverse events. Now, monotherapy is a bit trickier. Monotherapy by non-statin agents still lacks evidence for the prevention of CV outcomes and should be considered on an individualized basis as a last resort for defined statin intolerance, for diagnosed statin intolerance. Okay, something that in practice people do like to bring up about red yeast rice. What is red yeast rice? Well, it is a lipid-lowering agent of natural origin, which contains the bioactive compound monocolin K, which is structurally identical to lovastatin, well, nature's lovastatin. And a meta-analysis of 20 RCTs of red yeast rice actually showed that its LDL-C lowering activity was as effective as moderate intensity statins and was not associated with any alarming adverse events. So pretty interesting, but in terms of CV benefit, not proven. Okay, so I bring us to the final leg. Thank you for Thank you very much for your attention. We will talk about proposed algorithmic management of statin-associated muscle adverse events. Now, if their CK levels are normal, this is a workflow published in EHJ in 2020 that I think is reasonable and easy reasonable to implement. First, we would want to exclude other causes of muscle symptoms and interactions. Really just run a marathon. Okay, take time for the patient. Continue to tell them about the value proposition of statins, engage them in conversation so that they know potentially what they could be missing out on if they give this therapy up. We'll give them a break, 3 to 4 weeks, okay. If there is no resolution of symptoms, search for other causes of it. Okay. If the symptoms did resolve, okay, maybe temporarily it could be due to statins. What I would do, what this flowchart recommends is to restart the statin. You could use a different statin or start with a very low dose. Slowly increase, maybe every 2 weeks, to establish the highest tolerable statin dose, at which point you check the LDL and you see if the goals are reached. If they are not, that's when you would combine with non-statin therapy. In Singapore, we've got ezetimibe and PCSK9 inhibitors. So I'm sorry for the busy slide. I will draw your attention to this. So this is actually an algorithm that would be applicable if your patient has symptoms and or elevated CK levels. So again, you would want to inquire about their muscle symptoms, apply the questionnaire, the SAMCI questionnaire that I mentioned. In this pathway, a few thresholds that we would want to note. The presence of SAMs and or a CK level of greater than 5 times the upper limit of normal will necessitate statin withdrawal followed by close monitoring. If the CK is greater than 10 times the upper limit of normal, this proposes an additional assessment of renal function together with rehydration if needed. If the CK level is less than 5 times the upper limit of normal, it is reasonable to continue statins, and it would be pretty similar to the flow sheet presented in the earlier slide. You would start them lower, change the statins over, monitor them, titrate up slowly. If their symptoms, however, and this is assuming their symptoms have resolved, and then you would add on non-statin therapy, etc. Now, when do you need to refer to a specialist? I would refer to a specialist if after stopping the statins, the symptoms have not resolved and or the CK is still persistently 5 times the upper limit of normal. Okay, and it's in this box here. Which are the relevant specialists? Well, if you can demonstrate proximal myopathy, a neurological review is not unreasonable. Otherwise, a rheumatological review is what I would usually send on. So in conclusion, the benefits of CVD risk reduction by statins are borne out by decades-long evidence. Preventive effects are more substantial with more intensive statin regimens. It is a common misunderstanding to consider all statin adverse muscle events equivalent to statin intolerance. Statin intolerance is a diagnosis that should be confirmed after rigorous investigation with structured questionnaires and impartial evaluation of the causality and timeline events, bearing in mind that a uniform definition for statin intolerance is still lacking. Statin-associated muscle events are the predominant and most extensively studied adverse events, although in most cases they present without clinically relevant elevation of creatine kinase. Managing this involves iterative steps of assessment and adjustment of medication dosages. Statin-based approaches should be prioritized over non-statin approaches as far as possible. Thank you for your time, and we will move into the panel discussion. We will have Dr. Eugene Yang, Dr. Lipid of Low Cardiology Clinic, Dr. Patrick Lim, Senior Consultant at Khoo Teck Puat Hospital, and Dr. Ong Hian Ee, our President of the Singapore Cardiac Society, moderating.
Hi, thanks, Natalie. As usual, yeah, the toughest topic, which is statin intolerance. There are plenty of questions. I hope I've got enough time to go through all of them. Probably my first question, there was a couple of questions on utility of treatment of HDL and triglyceride. Perhaps I could get Dr. Loh Lip Ping to chime in on this. The utility of treatment of HDL and triglyceride.
Okay, the first comment is on triglycerides. You can hear me, right?
Yes.
Can you hear?
Excellent.
Okay. treatment of triglycerides. Triglycerides is really not as important a factor for atherosclerosis. Nevertheless, a high level of triglycerides, as you know, increases the risk of pancreatitis. And so I do not usually advocate any specific treatment for triglycerides unless the level goes up beyond 300 milligrams per deciliter. Most of the time, I think the advice would largely be restricted to a healthier diet, lower fat diet, physical exercise, weight reduction, and so on. If the patient still has a very high level of triglycerides, consistently above 300, then yes, I would consider putting the patient on fenofibrate, which I think is the safest probably of all the fibrates. Yeah.
Does anyone else want to chime in? And Prof. Tan, do you want to add in your thoughts about HDL?
I think the treatment trial for HDL has been uniformly disappointing. But I think the management of triglyceride forms part of the overall treatment in the patients with a dyslipidemic profile. And if you look at some of the clinical trials for secondary prevention, when you try to lower triglyceride, there is actually continued benefit over and above the LDL reduction. So, for example, if you look at the reduced EAT trial using a very purified form of omega-3 fatty acid, there's actually benefit from lowering on the LDL. Mind you, the entry level of that trial for triglyceride is more than 1.5. So it's actually a very low level that we are operating on. So I think for specific group of high-risk individuals, and when you have a concomitant TG level, I will continue to manage it and work on it. And this is over and above, of course, lifestyle modification in terms of reduction of alcohol, exercise, weight reduction, as well as the exclusion of secondary causes such as hypothyroidism or poorly controlled diabetes.
Okay. Maybe a next question. There's a question on the type 2 diabetes. Probably I'll ask Dr. Eugene Yang what he thinks. Type 2 diabetes and above 40, should we blanket start them all on statins?
Yeah, thank you for the question. I think I tried to answer that in the chat box. Mm-hmm. So if you look at the ACC guidelines, they recommend for patients who are diabetic between the ages of 40 to 75, if the LDL cholesterol is greater than 70 or less than 189, then statin therapy should be initiated. The question that was asked was about patients less than 40 years of age. And I think the reason behind why it's not recommended is, one, because of lack of data in terms of outcomes, and two, that overall the risk of cardiovascular events in that population, although higher than the general population, is still low, and consequently, whether there's a real benefit to earlier initiation of treatment is just unknown. So that's a primary reason why it's used as 40, the age cut.
Okay. I have a comment on this. I think it is worthwhile in these patients who are less than 40 years old, diabetic. I think what Hui Jim spoke about earlier on, doing a CT coronary calcium score might be useful in these patients, because I have encountered young diabetics below the age of 40 in whom a CT coronary calcium score has been very high. So I think these patients might want really to be quite aggressive in lipid lowering and controlling LDL cholesterol.
Okay. There was a question on local risk scores. Maybe I ask Patrick. Patrick, you work in London and you work in Singapore as well. So what do you think of the local risk scores, or have you tried using a local risk scores?
I mean, the most up-to-date would probably be using the ASCVD, isn't it? So I think that's why most of us are practicing. The local risk scores can be utilized again, the same as the Framingham study. So I don't particularly think that either way is right or wrong.
Mm-hmm. I do use a QRACE. What have you used a QRACE before?
QRACE is a population study. So this was based on using a population health study. So it's very similar to it's a GP practice based. So I mean that's something we use, but then it's also accounts for ethnic. Again, not very applicable in Singapore, and also based on your postcode, I don't think we can use that in Singapore.
Yes, we don't have postcode here. Yes, right.
Yeah, can I comment on that? So I think that is one of the major limitations is the lack of ethnic specific, risk score calculators. The Q risk score, as pointed out, has sort of a multiplier based on country of origin of immigration in order to sort of either increase or decrease risk based on, depending on the country of origin and population within the United Kingdom. And so I think that, that is one of the challenges with Singapore being a very heterogeneous country, trying to really accurately estimate risk when you have South Asians, Chinese, Southeast Asians, I think is very difficult. And that does remain one of the major challenges to appropriately either aggressively treat certain populations versus potentially over-treating populations who are at lower risk. And so that is something that we need to really address.
Yes. One more question is on very, very low LDL. I think, Paul, you had some, you answered this on the Ebbinghaus. I can't remember, is it Gauss or Ebbinghaus that very, very low LDL and their mental status and all that?
Yeah, I think there was a question that I thought, maybe I can bring it up for discussion is if the idea is raised to zero on the high risk group of patients, should we have the same application of raised to zero for the moderate and lower risk group of patients? I'll be keen to hear what the other panelists have said. Maybe I think, I hear what Eugene mentioned about, the cost effectiveness on the relatively lower risk group patient. Is it really still worthwhile? And knowing the cost of some of these drugs, especially the newer PCSK9, are quite expensive. My take is maybe using the risk score, you should really still be focusing on higher risk group patients, but happy to hear what the panelists have said.
Yeah, I will say that, to be transparent, that I was an investigator for the 488 trial here in the United States. And so I do agree that, we don't really, if you look at the ACC guidelines, in fact, they for the PCSK9 inhibitors from 2018, they're sort of, I wouldn't say indifferent, but they're uncertain about the value and role of PCSK9 inhibitors because of lack of cost effectiveness data. So I think until we have a better understanding of that, I do agree that it's really reserved, and even the guidelines articulate that it's really probably for the very high risk patients, those who've had multiple events or have at least had a history of ACS and have multiple risk factors. That really is probably the target population. We don't really have data for those who are sort of in a lower risk category because the 488 trial was designed for patients who had a history of MI, stroke, or peripheral arterial disease. And so in lower risk populations, we just don't know what the benefit would be in those cohorts.
Prof. Tan, what do you think? Raised to zero for low, moderate risk people?
No, I think if you are at in the risk to in the low as well as the moderate risk category, this is where your risk score and your risk stratifications comes in. I generally don't believe in treating patients aggressively who is at a risk score which is low in terms of its risk profile. I think it is the moderate group of patients that we oftentimes face with in our daily clinical practice as to whether we should start statin or how low should we go and so forth. So this is where the imaging comes in. I think this is where calcium score comes in terms of risk modifying. And so I would say that very high risk, there's no question. Low risk, don't bother. But I think it's the moderate risk group of patients that we need to assess further in deciding whether to treat or not.
Okay, Prof. Lo, what do you think? Low, moderate risk people leave alone, or?
Yeah, I think to some extent this is a cost effective. If treatment were not so costly, when we use the more potent LDL lowering medications, then I see no reason why you should not start earlier and give everybody a head start. Because obviously, as you get older, the effect of LDL cholesterol is going to accumulate, and you're going to have a bigger chance of accumulating plaques. So I think partly it's a question of cost effectiveness. To some extent, probably also we don't really have such long-term evidence on the safety of starting people on lipid-lowering therapy at a younger age. But I've always wondered why we choose quite often to start LDL lowering therapy in patients only after, say, 30 or 40 years old. If you already have a significantly high LDL cholesterol level, I see no reason why you cannot start already treating the patient when you say 15 years old, for example.
I see. So perhaps, Natalie, there's actually a lot of questions on statin intolerance, but perhaps I may ask you first. We move from low to moderate to very, very old people. There's some question about, should you stop statin when they're like 90 years old?
I don't, but in general, I do think that if a patient at 90 comes in with a long list of medications, there's the real polypharmacy is real. I would definitely try my very best to keep them on the statins, bearing in mind the real life limitations. I don't see age as an impediment to continuing statins. If anything, they would benefit the most.
Okay, we'll get back to you shortly. But Patrick, what do you think about the very old? Would you like actively stop statins for 90-year-olds?
I think this boils down to what we're trying to prevent. I think if you're 90, and I think we're trying to I think it depends really how much. I mean, we shouldn't be ages, isn't it, at the end of the day. If it's a good structure, it's a good physiologically young 90 years old who's functional, so I think we shouldn't be ages. But I think if it's a 90-year-old that's probably heading to end of life, then rationalization, I think it's not by age, by substrate. And there was a good question also, I think, about the CAC score. I mean, can I just ask, who would do serial calcium scores and over what period of years? Just curious.
Well, I think if your calcium score is already high to begin with, there's no need to repeat anymore, because it just makes sense. It's already gives you the information and the evidence to start therapy. But when you have somebody who is have fairly high cholesterol level, and right now the calcium score is 0, and typically I see in many middle-aged women with very high LDL 170, 190. HDL is also high, but yet no symptoms, no other risk factors, and calcium score is 0. For such individuals, I might just follow them up 10 years later with another score just to see how it goes. But certainly it is not meant to be a 0-2 to guide therapy, which some people were advocating.
Would you do a proper coronary CT, because they can have plaques without calcium?
It is true. Actually, 16% of coronary plaque has got no calcium, probably indicating a very, very early sort of plaque formations without the calcifications coming in. Most of the time, I would just order the entire CT coronary angiogram. I don't order CT calcium alone because...
Eugene, is that your experience in Seattle?
I'm sorry, what was the question?
So the question is for some of the middle-aged women, they may have negative calcium score, but they may have soft plaques. Have you this experience in your state?
Yeah, I think there are definitely cases where if you do calcium scoring or you do testing, that looks for hard plaque, that in rare cases, and we know that happens, that those patients may have soft plaque obstructive coronary disease. In fact, I have a patient just hospitalized today who had a CT scan for screening for TAVR, and his left main looked non-calcified, but he had a low ejection fraction that was new, and he got cast, and he had a very high grade distal left main stenosis that was angioplasty consented today. So yeah, I think we know that clearly a small percentage of patients with calcium scores of 0 go on to have cardiovascular events, but that proportion of those patients is very low. The issue about sort of discontinuation of statins that was mentioned earlier, I think it's just an individualized patient decision, right? If a patient comes to you and you're trying to decide whether to continue statin therapy or not, I think we use shared decision-making to really decide whether to continue the therapy or not, especially those who have no overt atherosclerotic cardiovascular disease. For those who do, then we usually try to maintain treatment indefinitely unless the patient's quality of life changes.
Maybe ask Prof. Paul, is there a role for adjuvant calcium score and carotid scanning?
Thanks, Henny, but that's actually looking at different aspect. Carotid scanning, basically looking at intimal thickening and looks really at the atherosclerosis field, and is looking at different regions of atherosclerosis. I think it will be additional in terms of benefit. Thank you.
Okay.
I just want to comment here is that the carotid intimal medial thickening has got no prognostic value at all. It is the presence of carotid plaques that is adopted as a risk modifier and stratifier in the ESC guidelines.
Can we come back to this? Can we come back to this question of statin therapy in the elderly? And I want to ask Natalie a related question. One of the suggested statin side effects sometimes is impairment of cognitive function, and we know that impairment of cognitive function tends to increase as you get older. So if you are going to advocate giving statins to a say 80-plus-year-old man or 90-year-old plus person who has got some evidence of maybe atherosclerosis and LDL cholesterol, are you going to consider this question of cognitive impairment in this patient?
Prof. Loh, thank you so much for the question. I think that in the literature, with regards to cognitive impairment, there has been no association with statins for cognitive impairment. And if anything, as a cohort for mixed dementia, including Alzheimer's and vascular dementia, the statin cohorts have shown better outcomes than non-statin treated patients. So I will still persist, even in the elderly cohort. I don't think statins are a reason to be concerned about in terms of cognitive regression. There is no proof.
We're running out of time, but there are actually a lot of questions for statin side effects. I'll target one to Natalie. Q10 and statins, any use?
No, I'm so sorry to say. Very much like lipophilic, hydrophilic statins, and also this position about CoQ10, being in its production being impaired because of the HMG CoA's reductase inhibition. Yes, okay. I mean, we do see changes in biochemical levels. However, when it comes to actual improvement in adherence or a reduction in reported symptoms, it has not been reported in the literature that CoQ10 ameliorates this.
Yeah, I think like Henny says, so we are really running short of time. We're 90 minutes into the webinar, and still 500 over people are still sticking with us. A lot of the questions we couldn't answer because there's not enough time. But what we'll do is we'll try to collate those questions and we'll run it through the panelists and try to give you a kind of a summarized answer for the participants, and then we'll have that posted to you as well. So because it's already we're 30 minutes past our time, I think it's only appropriate we conclude here. Firstly, I want to thank all the speakers and for preparing the slides and such excellent presentation and such great discussion from the panelists, and also Dr. Eugene Yang, who is still with us after 90 minutes of this intense discussion. And of course, all of you who stuck with us for almost 90 minutes. And I hope you can learn something from this webinar. And also, remember, you try to fill out this feedback form. The QR code, so you can just scan it off the screen. And we'd like to invite you to just stay focused. There's going to be another webinar coming on in about 3 months' time on a totally different topic, of course. And hope to see you then again. So take care and have a great weekend.
Thank you.
Oh, one more thing, of course. I'd like to thank Amgen for supporting this webinar. This is truly a special gift for us, and thank you very much for your support. Bye.